Assalamu alaikum. This presentation is on halitosis, the bad breath, the causes, the investigations, and the treatment for ENT and dental students and trainees. A pragmatic working definition for halitosis or bad breath or oral malodor is a malodor beyond a socially acceptable level. It's quite common. It's among the 100 most common causes for seeking medical help, and the third commonest cause for seeking oral or dental consultations. It basically arises from putrefying bacteria on the tongue dorsum and the periodontal membranes that produce by putrefaction of food remnants, saliva, and remnants of blood and other body fluids, volatile sulfur compounds. These are the compounds that causes the malodor. And they are basically three of them are particularly important: the hydrogen sulfide, the methyl mercaptan, and the dimethyl sulphide. In addition, there are contributions from other chemicals, including polyamines, diamines, and short chain fatty acids, all contribute to the halitosis. And this is the agreed classification of the different types of halitosis. The real halitosis is when the subjective complaint from the patient can be objectively assessed and measured. This can be temporary, or this can be coming from oral causes or coming from extraoral causes, either through the bloodstream or through direct passage from, for example, the nose or the lungs. All these are real halitosis, or they could be psychogenic, and this would be just less than 20% of the subjects. And these psychogenic halitosis, the patient will be bitterly complaining from the malodor, but there would be no objective tests and to quantify it. And if the patient can be ultimately convinced that he does not have real halitosis, then he would be classified as pseudohalitosis. But if they insist, despite all the evidence, that they have halitosis, then they will be classified as halitophobia, which is much more difficult to treat than the pseudohalitosis. In the real halitosis, it can be temporary after eating certain types of food, like, for example, garlic, or after a night's sleep, or after fasting. It can come from the mouth, from either the back of the tongue or periodontal membrane. It can come through the bloodstream from distant organs like liver, hepatic failure or kidney failures or endocrine problems, or it can come from nearby organs like the sinuses, the nasopharynx, or the lungs in extraoral halitosis, but not blood-borne. Chart would further illustrate the classification of halitosis, the true genuine halitosis, which can be either physiological or transient halitosis after a night's sleep or after eating certain foods or drink, or pathological, which can be either intraoral or extraoral, and the extraoral can be further subdivided into those coming through the bloodstream from distant organs or from nearby organs like the nasopharynx, the nose, or the lungs. The other cause for the halitosis will be the psychogenic or the delusional halitosis, and if the patient can be ultimately convinced that he does not have objective halitosis, that this is pseudohalitosis, but if he insists that there is a problem despite the evidence, then this is halitophobia. Physiological halitosis, the transient type, after a night's sleep, as often referred to as a morning breath, or after fasting, and it resolves quickly after eating or drinking or a mouthwash. This is basically due to increased microbial metabolic activities during the sleep due to the reduction in the salivary flow at night, and also due to the lack of the physiological movements in the oral cavity to clean it, such as the movement of the facial and the oral muscles. Some females would manifest higher volatile sulfur compounds level than men in the morning, particularly in relation to the days of their cycle, as we shall see later. Transient halitosis after consuming certain foods or drinks are non-pathological halitosis. They are lifestyle related. They are related to things like smoking or ingesting certain foods or drinks, including things like garlic, onion, spices, radish, alcohol, and certain drinks that may dry up the mouth, such as alcohol-containing liquids, including wines and mouthwashes, or dairy products. Often the breakdown of the dairy products in the mouth could release certain amino acids that are rich in sulfur. The subjective or the delusional type of halitosis is basically self-reported malodor without a detectable malodor or halitosis, cannot be objectively perceived by others. It may reflect a monosymptomatic hypochondrial psychosis. It can be classified into two types, either pseudohalitosis, where the subjects eventually accept that they don't have halitosis after reassurance and some simple oral hygiene methods. And these are the vast majority of the group of subjective halitosis, amounting to about 16% of the total subjects presenting with halitosis. A small group of patients would have the persistent fear of having halitosis despite reassurance. This may affect the subject behavior. They would present with things like constant attempts at covering their mouth when they are talking and avoiding people, and they are fixated with cleaning their teeth and the tongue, and they misinterpret other people's behavior. If people start sniffing, for example, or opening windows or touching their nose, this will be taken as gestures that they have halitosis. Females are significantly more in this group. Certain medications like selective serotonin reuptake inhibitors can show some improvement in the group of halitophobia who have the persistent fear of having halitosis despite reassurance. Real halitosis, the pathological type, can be subdivided into intraoral halitosis. This is the vast majority of the patients, and extraoral halitosis, whether coming through bloodstream or coming from nearby organs, they form the minority at less than 4%. Factors that provide the ideal environment for producing these chemicals and producing halitosis are dry mouth, either during sleep or nasal obstruction or smoking or alcohol, or from oral and dental malhygiene that allows gram-negative anaerobes to load inside the oral cavity, or from constant irritation of the oral cavity mucosa from laryngopharyngeal reflux or smoking that would irritate and also reduce the salivary flow. For the intraoral halitosis, the most common would be halitosis from organisms in the back of the posterior part of the tongue, from tongue coating in this area. This would be just less than half of the cases in the posterior part of the dorsum of the tongue. And there may be contribution from other causes like oral candida or herpes, or diseases related to oroantral fistula, or even oral tumors and ulcerations. Gingivitis and periodontitis are the second common cause for intraoral halitosis. They produce high levels of methyl mercaptan, and if the methyl mercaptan level is very high, and it's more likely than not that the patient had one or more periodontal pockets. The incidence of periodontal pockets in the high methyl mercaptan group would be much higher than the low methyl mercaptan group. If a periodontal pocket is deeper than, for example, 4 millimeters, then it would provide the ideal environment for a reduced oxygen tension and a decreased pH. This acidic environment is necessary for the activation of the decarboxylation of the amino acids to give the malodorous diamines. The other reason for halitosis from the gingiva and the periodontic membrane is Vincent angina, not very common, but it is associated with a severe type of halitosis. Extraoral halitosis is far less common than intraoral halitosis. is either caused by malodor from nearby sites, like for example the ear, nose and throat region, including the tonsils that contribute to about 3% of the cases of halitosis, or from the pharynx affected by laryngopharyngeal reflux or certain granulomas or even malignancy. The most common cause for halitosis from the ENT sites would be tonsillolith, the tonsil stones. These are mineralized debris in a deep tonsil crypt, usually the crypta magna. And if this is the case, then there is a tenfold increase of the risk of abnormal volatile sulfur compounds compared to those who don't have the tonsil stones. It's again anaerobic bacteria that will be detected in the tonsillolith, the same type of bacteria that is associated with volatile sulfur compounds production. The other common site in ENT for halitosis would be the nose and the nasopharynx. Nasal obstruction would lead to mouth breathing, perhaps postnasal drip and crusts, or nasal foreign bodies, or even malignancy, particularly in the nasopharynx. Again, foreign bodies or sinusitis or cleft palate can all contribute to malodor. Infections in the sinuses or granulomas can also add to other ENT causes of malodor. And halitosis can be caused by exhaled chemicals from the lower respiratory tract, for example, from a lung abscess or infection, bronchiectasis, or lung cancer, or endobronchial chronic disorders can all produce malodors, volatile compounds that can be exhaled and perceived as halitosis. 1 in every 200 cases of halitosis would have the cause in the GIT. This can be basically gastroesophageal reflux or laryngopharyngeal reflux, that's the main cause, but also things like hiatus hernia, pharyngeal pouch, H. pylori infection, or gastrointestinal cancer can contribute to the malodor. A particular type of halitosis caused by the GIT is quite rare, but it has a very characteristic odor caused by intestinal obstruction. It gives a fecal mouth odor. Then there is the group of the less common causes of halitosis coming from distant organs due to systemic causes that would release the malodorous chemicals into the bloodstream that would eventually reach the tongue and will be exhaled in the breath. This would include things like acetone-like smell for uncontrolled diabetes, or a uremic breath in renal failure, or fetor hepaticus in liver disease, or metabolic disorders, including trimethylaminoria that would give a fish odor type of breath, or tyrosinemia, which would give a cabbage-like odor. All are metabolic disorders releasing malodorous chemicals into the bloodstream. In addition, the changes in the hormonal levels could also be reflected in the breath. Increased progesterone levels during the menstrual cycle would give a typical breath odor, and also the volatile sulfur compounds levels in the expired air may increase between 2-folds and 4-folds at the day of the ovulation and in the days just before this in the premenstrual period. Then some medications are also known to produce transient or recurrent halitosis, including the biphosphonates that may cause osteonecrosis in the mandible, or compounds containing lithium or melatonin or metronidazole or nicotine lozenges, plus compounds of nitrites and nitrates and phenocyanidins and amphetamines, plus some cytotoxic drugs and some compounds containing sulfur, and medications that can result in dryness of the mouth. And finally, there may be other much more sinister causes for the halitosis, including malignancy, and this would result from advanced tumors causing superficial necrosis, ulceration, and secondary infection. There would usually be other features of the tumors like a mass or lymph nodes in the neck, or dysphagia or dinophagia, trismus or ankylosis, or a cough, chest pain, hemoptysis. You could see patches with different colors, red or white, that may indicate leukoplakia or erythroplakia, or you could have a typical enlargement and swelling of the gingiva that may reflect, for example, certain hematological tumors, including leukemia. The amount of the volatile sulfur compounds in patients who have malignancies are much higher than in controls. The sulfur compounds in malignancies with the gray color is much higher compared to those in the control groups with the black color, including hydrogen sulfide and other volatile sulfur compounds as well. Now move to investigations for patients with halitosis, how the patients with bad breath be examined and how the bad breath can be quantified. The objective detection and quantification of halitosis would depend primarily on the detection of volatile molecules in the patient's breath. These are primarily the volatile sulfur compounds, but not exclusively so, because other compounds could also give a bad odor. The volatile sulfur compounds are primarily three: hydrogen sulfide and methyl mercaptan. These two accounts for 90% of the bad odor emanating from the oral cavity. The third, the dimethyl sulfide, accounts mainly for the extraoral halitosis. But as mentioned, there will be other chemicals that also contribute to bad breath, including things like diamines, putrescine, and cadaverine. Hydrogen sulfide would give the odor of rotten eggs. Methyl mercaptan would give the odor of a rotten cabbage. Dimethyl sulfide would give an unpleasant odor as well. Other odors of garlic-like odors would come from allyl mercaptan and allyl methyl sulfide. And there would be also the odor of ammonia and a fishy odor for dimethylamine or trimethylamine. Certain precautions should be taken before assessment of the halitosis. The patients should be advised to refrain from consuming spicy food, garlic or onions, 24 to 48 hours before the examination, and should also refrain from brushing their teeth or rinsing or cleaning their mouth at least 12 hours before the consultation. They shouldn't be wearing any perfumes at least for the last 6 hours before the examination, and ideally they should stop smoking 24 hours before the examination, and in the morning of the examination only drinking water should be advised. This is the first step in the assessment of halitosis patients, evaluating the patient's own perception of their condition. And there's a very good reason for this, because there is a very strong correlation between the patient's self-assessment and the objective results obtained from machines like analyzing the volatile sulfur compounds levels in the patient's breath. The patient's own perception would help in confirming the diagnosis, identifying any underlying cause, and determining any impact of the condition on their quality of life. Several questionnaires are used. This questionnaire from the Basel University Halitosis questionnaire includes 11 questions that covers areas like how and when did the patient came to notice that he has a problem with bad breath, and if this had any impact on his life or his behavior. Does he smoke or have any special diet or in any list of medications? What steps had the patient taken to improve his condition, including things like oral hygiene and mouth washing and toothbrushing, and whether the patient had sought medical help for this. Is he on any specific treatment, and whether the patient agrees that he has a problem with bad breath or not. The next step would be the organoleptic assessment, and although this is semi-subjective, it remains the gold standard for the identification of a bad breath, because it's easy to perform and it most closely resembles the daily situation. It's not expensive. It's done by experienced examiners. Preferably 2 experienced examiners would do the test, and given that the human nose can distinguish over 10,000 different odors, there is much more a chance of detecting certain volatile compounds than any available device in the market. In the expired air, there is more than 150 different chemicals that can cause bad breath. Assessing the air emanating from the nose and from the oral cavity is indicated. If the reason for the halitosis is extraoral, it would come only from the nose and not the oral cavity. And as mentioned, the test is ideally performed by 2 different examiners. The organoleptic test can be done in various ways. Primarily, the test is about the clinician or an examiner sniffing the malodor from the patient from a distance of 10 centimeters. The sniffing test would depend on patients closing his mouth for 2 minutes, followed by exhaling, and if the clinician could detect bad odor from a distance of 10 centimeters, then the test is positive. The count to 20 test gives some time for doing this. The clinician would be counting from 1 to 20 while waiting to detect any malodor in the exhaled breath after the patient had closed his mouth for 2 minutes. There are then 3 different tests in which the patient's saliva would be sniffed to detect if there is any malodor from a distance of 5 centimeters. This can be done by the rest lick test. The patient would just lick his own rest, and the clinician would try and sniff from a distance of 5 centimeters to detect any malodor, or the spoon test, in which a plastic spoon is used to gently scrape the dorsum of the tongue, and the clinician would again sniff from a 5 centimeter distance, or the flossing test, in which the patient would use a dental floss through his molar teeth, and the clinician would sniff the floss from a distance of 5 centimeters. The nasal odor test would be done with the mouth closed to detect if there is any extraoral odor or halitosis, and prosthesis odor can also be done if the patient have a partial or a full removable dentures, again to detect if there is any malodor in their prosthesis. Objective detection of malodor compounds would be carried out by gas chromatography coupled with a flame photometric detector. This can be performed on the patient's breath or his saliva or tongue debris. It's extremely sensitive and capable of detection of sub-nanograms levels of sulphur. Things like 0.5 nanogram of methyl mercaptan or 1.5 nanogram of hydrogen sulphide, for example. It would detect almost all the chemical compounds, volatile chemical compounds in the exhaled breath, and depends on a computer database to identify which chemical compound is present in what concentration. Things like in halitosis, for example, hydrogen sulphide level would be more than 1.5 nanograms in every 10 milliliter, and the methyl mercaptan level would be 0.5 nanogram in every 10 milliliter compared to the non-halitosis group. There is a portable version of the gas chromatograph, which is much more handy to use, and it is basically made to detect and discriminate the 3 most important volatile sulfur compounds. If it shows high levels of, for example, methyl mercaptan compared to hydrogen sulphide, this will indicate periodontitis, while if there is increased level of hydrogen sulphide, this would indicate bad oral hygiene because of accumulation of debris on the tongue surface. Increased levels of dimethyl sulphide is usually indicative of extraoral halitosis. The measurements are of course much more reproducible and reliable and sensitive than the organoleptic subjective tests. It can detect extremely low gas concentrations, but it is expensive, of course, and the results would not be shown in real time. It needs time to provide results. This is an example of results obtained from a chromatogram, which shows 3 different peaks for the 3 most important volatile sulfur compounds. Number 1 for the hydrogen sulphide, number 2 for the methyl mercaptan, and the third for the dimethyl sulphide. So in this example, if it only peaks with the hydrogen sulfide, it can be either due to the physiological halitosis after a night's sleep or after fasting, or it can be due to debris and colonization of the bacteria in the dorsum of the tongue. In the second example, you see peaks for the three of them, including a peak for the methyl mercaptan, and this would usually be indicative of periodontal halitosis, periodontitis, and periodontal pockets. There are also other ways of detecting sulfur compounds, including electrochemical reactions. This is a portable device that could monitor the volatile sulfur compounds using this electrochemical reaction, and it would give levels of the three most important volatile sulfur compounds. It's easy to use and less expensive than chromatograms, and it measures parts per billion levels. So if it measures anything less than 100 part in a billion part of exhaled air, this is normal. Between 100 and 180 parts, this is minor halitosis, and above 250 parts is due to chronic halitosis. Again, it would measure the levels of sulfur compounds rather than any other malodorous compounds in the exhaled air, but it is not expensive and much more practical to use and gives immediate results.
Electronic noses are chemical sensors. The equipment would have 6 metal oxide semiconductor sensors with different sensitivity and selectivity to various compounds in the expired air. They can sense the three different sulfur volatile compounds and can quantify them individually. It can be used selectively in, for example, the back of the tongue or directly in the gingival or periodontal pockets. So it can measure localized areas in there, and the results are fairly accurate. The next group of tests are specific halitosis tests designed to identify a certain cause for the halitosis. Starting with the BANA test, which is designed to identify the proteolytic gram-negative anaerobic bacteria and the short-chain fatty acids colonizing the periodontal pockets and the dorsum of the tongue. A test strip containing certain trypsin substrate called BANA, benzoyl D-L-arginine naphthalamide, would turn into a blue color if it comes in contact with plaques or pockets containing the proteolytic gram-negative anaerobic bacteria. The test is very sensitive, it is short, takes only a few minutes, and it has a very strong correlation with the presence of periodontal pockets and periodontitis. It can also identify 3 major bacterial groups causing halitosis.
Another test is the Winkel tongue coating index, which tries to quantify the degree of the tongue coating causing 50% of the causes of halitosis. This test is based on dividing the surface area of the dorsum of the tongue into 6 different parts and then quantifying for each area of them the amount of the coating between 0 where there is no coating at all, 1 when there is light coating, and 2 when there is heavy tongue coating. And then the results are added together for the 6 to produce an index. Later, it was found that a better validity and reliability of the results could be obtained by omitting the number 1, the light coating grading, because this reflects more the keratosis, the keratinization of the papillae of the tongue rather than tongue coating. So the modification of the Winkel tongue test was only for 2 grades, no coating or coating, and omit the number 1, and this gives a better results. We'll go with some details on the evidence for the management of the oral causes of halitosis that account for more than 85% of the total cases of bad breath, starting with the mechanical reduction of the oral causes, intraoral nutrients, as well as intraoral microorganisms, particularly in the 2 most common sites, the dorsum of the tongue and the periodontal membrane. Then we'll go through the chemical reduction of the microorganisms using various antibacterial agents, followed by how we can invert the volatile fragrant gases that causes halitosis, particularly the volatile sulfur compounds, into non-volatile components. And then we'll go through the techniques used for masking of the malodor, and finally we'll go through other new techniques including photodynamic therapy and lasers. The mechanical reduction of the tongue coating is one of the most important aspects in the management of halitosis, as tongue coating is the most prominent factor in the bad breath. The scraping of the dorsum of the tongue can reduce the available nutrients for the microorganisms and also reduce the microorganisms load itself. And although this can be done by the use of a soft toothbrush, there is evidence to support that the use of a special tongue scraper will produce better results. Since the largest amount of coating is found on the posterior part of the dorsum of the tongue, the scraping should start as posterior as can be tolerated by the patient. And to prevent any gagging or tendency for vomiting, it's advisable to protrude the tongue as far as possible anteriorly while scraping its dorsum. The two common techniques to scrape the dorsum of the tongue are the tongue scrapers or the use of a soft toothbrush. A systemic review of the results of both techniques had showed that although the use of either of them could bring about a 60% reduction in the volatile sulfur compounds coming out from the dorsum of the tongue, the use of the scrapers, the tongue scrapers, can reduce these volatile sulfur compounds by 75% and the use of a toothbrush by only 45%. The average for the two is about 60% reduction in the production of volatile sulfur compounds from the oral cavity. The other benefit of tongue scraping is that it seems to improve the sense of taste after scraping the tongue. The second most important cause for bad breath is periodontitis. A regular interdental cleaning by flossing and tooth brushing should be carried out on regular basis to control the formation of plaque and also reduce the microorganisms in the oral cavity. But if this fails to control the periodontitis, a one-stage full mouth disinfection has been described to be carried out by professional periodontal therapy, and this would combine full mouth scaling and root planning and then the use of an oral antiseptic like chlorhexidine. This type of therapy had showed prolonged effect for almost 2 months for a reduction in the microorganisms in the oral cavity and also improvement in the tests that quantifies halitosis like organoleptic scores. In addition to the mechanical reduction of the microorganisms and nutrients in the oral cavity, the use of chemotherapeutic agents to reduce the bacterial load is also important. The most common active ingredients in this group includes triclosan, chlorhexidine, cetylpyridinium chloride, zinc, and essential oils incorporated into toothpaste and mouthwashes in different concentrations. We shall go through them all one by one. Alcohol-free antiseptic mouthwashes can provide better results compared to antiseptic mouthwashes that has alcohol as one of its ingredients. Alcohol can cause dryness of the oral mucosa, limiting the effectiveness of the antiseptic mouthwash. A Cochrane systematic review was carried out to compare the effectiveness of different mouthwashes with different composition and in different concentrations. It showed that some of the ingredients are better in doing one particular task in reducing the volatile sulfur compounds, while other components can produce better results in another aspect. For example, the use of chlorhexidine plus the cetylpyridinium chloride can inhibit the production of volatile sulfur compounds, whereas the use of chlorhexidine with zinc can neutralize the sulfur compounds production by the oral cavity microorganisms. We would now go through the different chemotherapeutic agents one by one, starting with chlorhexidine, which is the most efficient molecule against plaque formation. Chlorhexidine inhibits this wide spectrum of microorganisms. It controls plaque better than any other molecule and prevents its accumulation, thereby improving the halitosis. Its method of action is penetration of the cell membrane of the oral bacteria, and this would cause cell leakage and disruption of the bacteria metabolism. It has been showed that the use of a mouthwash containing chlorhexidine can reduce the volatile sulfur compounds by as much as 43% for a full day, and can also reduce the tests quantifying halitosis by as much as 50% scores. The disadvantages of chlorhexidine includes the reversible discoloration of the tongue or the teeth or the dentures. And this can be minimized by brushing the teeth before the use of chlorhexidine mouthwashes, and also by use of another conventional denture cleaner to clean the dentures. There may be also a transient taste disturbance and some burning sensation with the use of chlorhexidine that usually settles with time. Another widely used chemotherapeutic agent in the management of halitosis is triclosan, which is an active ingredient in many of the oral health products. It is lipid soluble and has a recognized effect on plaque formation and has a bactericidal effect, particularly on gram-negative microbes. It reduces the production of volatile sulfur compounds, and if it is combined with a copolymer, it adheres to the soft and the hard tissues of the oral cavity for up to 12 hours. It has been shown that it can reduce the volatile sulfur compounds by as much as 84% for up to 3 hours. Cetylpyridinium chloride is very effective against plaque formation and also against the formation of calcified debris in the oral cavity. If it is included in mouthwashes, the effectiveness can be as much as 70%. It has few side effects. Zinc is another active ingredient that can be used in different chemical compounds and different concentrations, and also in different forms, either as a mouthwash, a toothpaste, a chewing gum, or even in a tablet form. It's very versatile for that reason. The zinc acts by inhibiting the breakdown of the proteins by the microorganisms in the oral cavity. And if it is successful in doing this, it prevents the transformation of amino acids containing sulfur into volatile sulfur compounds. This can, for example, be achieved by zinc acetate. Another form of zinc, the zinc lactate, can neutralize the volatile sulfur compounds by transforming the sulfides into sulfides, and these don't have any or unpleasant odors. It can be incorporated into chewing gums and can be used as a supplement. Another active ingredient is the fluoride compounds. Amine fluoride and tin fluoride in combination can cause 83% reduction in the morning halitosis. These two compounds inactivate the oral bacteria on the surface of the tongue and thereby reduce the production of volatile sulfur compounds. Sodium fluoride can be incorporated into chewing gums. Other active ingredients include essential oils, for example thymol, menthol, or eucalyptus. They can destroy the bacterial cell wall and also inhibit some of the bacterial enzymes. They also give a fresh odor to the breath. They can only work for short periods. Their effect is restricted to about 3 hours and produce only about 25% reduction in volatile sulfur compounds activity. Other less used agents include things like hydrogen peroxide. It is claimed that it can produce as much as 90% reduction in the production of volatile sulfur compounds for up to 8 hours. In addition to the Cochrane systematic review, there had also been some recent randomized controlled trials. Some of them were double-blind crossover trials that had looked at a combination of some of the individual active ingredients. And one such a trial looked into the effect of zinc acetate in addition to chlorhexidine as a mouth rinse, and showed that a certain mixture of zinc acetate and chlorhexidine could give a clear and durable effect in the inhibition of intraoral halitosis for up to 12 hours. Chemotherapeutic agents are usually used as a mouth rinse or a toothpaste, sometimes a chewing gum, but can also be used in the form of tablets. And there are supplements of zinc that can be used for this reason, and some tablets of dihydroascorbic acid that can be used as an oxidizing agent to neutralize the volatile sulfides. There are also tablets with chlorophyll and active carbon tablets. The chemotherapeutic active ingredients can be used in the form of toothpaste. Things like stannous fluoride, zinc, or triclosan are widely used as a toothpaste. They offer some beneficial effect in the reduction of the malodor, but only for a limited period of time. And then this is another approach to the problem of the volatile sulfur compounds. This is the use of chemicals to neutralize its effect rather than stopping its production. And it can be incorporated into things like toothpaste, mouth rinses, and lozenges. The active ingredients of this group of chemical neutralizers are either metal ions or oxidizing agents. The metal ions, things like zinc, sodium, magnesium, they can interact with the sulfur ion and produce insoluble compounds like sulfides that is no longer volatile enough to cause the bad breath. The mechanism of this is that the metal can oxidize the thiol group of the sulfur-containing amino acids, the precursors of the volatile sulfur compounds. The oxidation process of the volatile sulfur compounds can bring about a reduction of about 29% of the cases of halitosis for about 4 hours in one study. The positively charged ions, metal ions, also can bind with the sulfur radicals, inhibiting the volatile sulfur compounds expression. So a mixture of these chemical neutralizing agents plus the antiseptic agents, active ingredients we have been through so far, can provide better results. And it was shown that mixing up of zinc plus chlorhexidine seemed to have a synergistic effect in the control of halitosis. One other way of trying to control halitosis is the old way of masking the effect rather than treating the cause of halitosis. It's not a treatment and it's not effective in the management of halitosis. Nevertheless, it can be used sometimes to mask the effect of the volatile sulfur compounds by the use of certain pleasant flavors and fragrances. Things like flavored mouthwashes or chewing gum or sprays with menthol, eucalyptus, or methyl salicylate are widely used. The results of the use of such masking agents, like chewing gum or sucking on a mint, are very short-lived. Some of the trials using these masking agents showed no certainty in the value of the use of such agent, like for example eucalyptus chewing gum or topical agents used in sprays. One mechanism for the action of these masking effect plus the freshness of the breath is that it may initiate more salivary production, and the increased volume of saliva can retain more soluble sulfur compounds for a short period of time. Advice on diet modification can also be of some help in the treatment of halitosis. Things like drinking sufficient fluids, not omitting breakfast, sucking on a sugar-free sweet or a chewing gum, sugar-free again if there is a sensation of a dry mouth, because this can promote some salivary production, stopping smoking and alcohol, the use of baking soda in the toothpaste, and the limiting of the frequency of consuming sugary food and drinks to 3 or 4 times a day with the meals. Also, a diet free of onion, garlic, and similar foodstuffs can also prevent the associated transient blood-borne halitosis. Treatment of gastroesophageal reflux is also of help. Another recent technique in the treatment of halitosis is the use of low-level lasers therapy. This was used initially in the management of mucositis in the oral cavity after treating oral cavity cancers with radiotherapy or chemotherapy. The evidence was reviewed by the National Institute of Clinical Excellence, and it concluded that the safety profile for low-level lasers showed no major safety concerns. It also concluded that the evidence on the efficacy is adequate in quality and quantity, and advised that this procedure can be used. The technique involves the use of red laser diode with a point application method and indirect contact with the tongue dorsum. The irradiation will be done in 6 points in the posterior and the middle parts of the tongue dorsum, with a distance of about 1 centimeter between the points. This is the summary of the treatment needs for the 5 groups. In TN number 1, the physiological halitosis group, the management is basically explanation of the halitosis and advice and instructions on oral hygiene. The focus will be on reinforcement of the patient's own self-care. This is the main thing here, the use of tongue scrapers, toothbrushes, mouth rinses, and different other self-care techniques. In the second group, the genuine oral halitosis, they would require also an explanation and advice on the oral prophylaxis and oral hygiene. But in addition, they may require to see their dentist for a specific problem, usually in the periodontal membrane. In TN number 3, the extra oral halitosis, they would require referral to the specific physician. It can be, the pathology can be in the lungs, or it can be in the kidneys, liver, or metabolic like diabetes. In TN number 4, the pseudohalitosis group, the patients are convinced they have halitosis, and they would require an explanation and a thorough examination and an explanation of their condition and education and reassurance. If they remain convinced that they have halitosis despite this treatment in combination with TN1 as well, then they would need to be referred to clinical psychologists, because they would fall into the group of halitophobia, the TN number 5. By this, we come to the end of this presentation on halitosis, the causes, the investigation, and the management for ENT and dental students and trainees. Assalamu alaikum.